In our discussion today, Dr. Vig and I want to go over with you some further aspects of the general subject of facial form analysis. What we'd like to do today is extend our previous discussions and talk with you about some of the functional aspects of facial form we observed in a clinical examination of a child patient. Then we want to review with you the relationship of the intraoral to the extraoral exam, and this time in the mouth to observe directly the relationships between the hard tissues and the soft tissues that overlie them. And finally, we want to discuss with you briefly what this is really all about and how you can use it in clinical management of patients.
Now, up till now, you have been shown how to look at faces in a fairly systematic sort of a way. It's a fact of life that not all people are ideal or normal, as you may guess by looking at your patients. By now, however, you should be pretty good at recognizing what's ideal and what's normal. Unfortunately, some people do have teeth that stick out and others have teeth which stick in, and so it's time for us to start to make some sense out of the whole business and try and put together all the features which tend to correspond to dental relationships and the facial form that you've been looking at. Now, there is nothing which guarantees in our genetic blueprint that teeth, muscles, and bones, which are independently variable and inherited independently, should fit in an ideal sort of a way. If they do, and if the harmony is good, we tend to have good occlusions. But more often, particularly in our mixed populations, we find the inherited features of skeletal, dental, and soft tissues are not exactly in harmony. And this is really what gives rise to the enormous range of variation in both facial types and the dental occlusions and relationships which we see in clinical practice. Now, you already know a fair bit about the teeth and the bones. So far, we've only been touching on the soft tissues in a fairly slight sort of a way. Today, what I want to show you is how to do a systematic analysis of soft tissues, and particularly soft tissues from a dynamic aspect. Now, by soft tissues, I mean lips, the mandibular musculature, and something about the behavior of these muscles. This is by no means a total picture, but it is about all we can see clinically, and I think it's what covers the salient features which we have to consider in the examination of a patient. Soft tissues have two characteristics which you should be aware of. Predominantly, you should be considering morphology, which is really the shape. So in other words, morphology of soft tissues is an important feature. And we also have to consider function. Under function, we look at such things as posture and behavior. Now, let's concentrate on the lips first. What about morphology? Well, although it would be nice to have a quantitative evaluation of morphological variation of lips, this is not yet available. But by looking at children, or even for that matter adults, we can make certain statements which will be agreeable to most other observers. We can say that one particular patient, for instance, has full lips, full, which may be everted. Another patient may be said to have thin lips. So here we have the two extremes in the morphological spectrum of variation of lips. Morphology of lips, therefore, may be full, thin, and anything in between that. We can also judge by knowing what the average looks like and what the range of variation in a population seems to present in terms of whether the lips are short or long. This is a descriptive term which is usually used to describe the upper lip. Some people are said to have a short upper lip, others have a long upper lip. Okay, now what about the function of lips? So far, we have been introduced to the idea of looking at lips at rest. You saw in the previous presentation that children may have incompetent or competent lip morphology and function. These two are interdependent. Soft tissues morphology is related to their function. So we may have lips which are competent, and as you remember, competent lips are those which, when the patient is relaxed and the muscles of facial expression are also relaxed, do come into light contact. On the other hand, we may have incompetent lips, which are functionally incompetent, and that means that when the patient is relaxed, the lips are apart. To bring them into contact, you do require some degree of effort, some circumoral contraction, and this is clearly visible by looking at the facial appearance in general, and particularly in this region here, in the mantalis region, where you can see the activity, which shows as a puckered sort of appearance of the skin there. Now, one thing I would like to stress, and that is that incompetent lips, although giving the patient the appearance of breathing through the mouth, are not indicative and not diagnostic of mouth breathing. In days of yore, or long ago, this sounds like a fairy story, but it's true, lip incompetence was not described in these terms. There was a characteristic facial appearance which orthodontists used to call the adenoidal facies, F-A-C-I-E-S. I'm telling you that because my pronunciation may be different to yours. Adenoidal facies was the descriptive term used for an individual with a long face, usually with a high Frankfurt mandibular angle, who was lip incompetent. And because it was called adenoidal facies, the natural reaction was to remove the patient's adenoids and tonsils. Now, in England, there is a street called Harley Street in London where all the richest and best surgeons live. And it was said at one time that adenoid and tonsil removal helped these surgeons provide themselves with annually renewable Rolls Royces, but did nothing much for the patient's health or facial development. This is our belief now, and I just thought that you ought to know that incompetent lip morphology and function is not the same as mouth breathing, not underlined mouth breathing. If you want to establish whether a patient is in fact breathing through the mouth or the nose clinically, all you have to do is get a cold or chilled mouth mirror, place it under the patient's nose, and if it fogs up, then there is air coming in and out through the nostrils. If you place it under the mouth or in front of the mouth, it'll always fog up. So you have the frosted, shiny side up under the nose like that, and that will demonstrate clearly that there is nasal respiration going on. Okay, now what about the mandibular musculature? Morphology is impossible to establish. However, we can have a look at some functional aspects of the muscles of the mandible, muscles of mastication, as they're sometimes referred to. Now, the functions that we look at are those which relate to mandibular posture, and mandibular posture is best assessed in two ways. First of all, by reference to the freeway space. Freeway has two E's. And secondly, to the path of closure from habitual rest or resting relaxed position of the mandible to the position of maximum intercuspation. So we have freeway space and path of closure. Now, the normal freeway space, which is measured between the bicuspid teeth, would be between 2 and 4 millimeters on an average. There are variations, but that's the sort of normal range you should see. The path of closure should be normally upwards and forward from rest into occlusion. However, some people do have an upward and backward path of closure. Now, whilst we're talking about path of closure and occlusion, we ought to remember that we ought to check in each case whether there is a discrepancy between the centric relation and centric occlusion. In other words, we have to detect mandibular shifts, which may be forward or sideways, or in some rarer cases, in a distal direction. If we miss this out in the assessment of the path of closure or mandibular musculature, we may be led into incorrect assumptions about facial asymmetry or degrees of prognathism. Now finally, under consideration of soft tissues, we have to look at the way in which the patient swallows. Now this isn't always easy, and you have to practice this for a while on a few patients. I'll try and demonstrate that to you in a minute, but what we're looking at is the way in which the lips and sometimes the tongue are involved in producing a swallowing activity, and specifically how the front of the mouth is sealed off during swallowing. So what we're really looking at is the type of oral seal production, oral seal, which may be simply with the lips coming into contact. In other words, it may be a lip-to-lip seal, or the tongue may be involved as well, so that the tip of the tongue comes over the lower incisor teeth, comes between the upper and lower teeth, which are now separated. In other words, the teeth are apart, and the tip of the tongue contacts the inner aspect of the lower lip. And this is referred to as a tongue-to-lower lip oral seal. And this is precisely the same thing that some people call a tongue thrust. Tongue thrusting seems to have certain connotations nowadays, and I think that a tongue-to-lower lip oral seal production with a tooth apart swallow is less emotive and less likely to raise eyebrows in certain quarters. But the two terms, these terms are synonymous. Okay, now I've given you a brief account of how soft tissues function in relation to the things that we're looking at, and I'm going to try and check these things out on a patient for you. But before we get on to the patient, I think the other thing that we have to be absolutely certain about is that we are in fact using the same descriptive terminology when it comes to describing the position and relationship of the teeth. In particular, we're interested in the sort of terms that we use to describe the relationship of the incisors. Now here we have what looks to be a reasonably normal or ideal incisor relationship. As you remember, the vertical overlap of the upper over the lower teeth is what we call overbite, and variations in overbite may go from normal to an increased overbite. Normal is where the upper incisor crown overlaps the lower incisor by about 1/3 of the lower incisor crown. An increased overbite is where there's a greater degree of vertical overlap. The other extreme, we may have a reduced overbite, which may be as reduced as edge to edge, like that, or in extreme cases, we have failure of vertical overlap of the front teeth when the cheek teeth are together, and this is what we call an anterior open bite. The other thing that I like to look at when I check out the overbite is whether there is contact between the lower incisor tip, in other words, that point there, and anything in the upper jaw. It may be upper teeth or upper gingiva or even the palate. If there is contact, we call that a complete overbite. If there isn't contact, it's an incomplete overbite. So the descriptive terms for overbite may be increased, decreased, or normal, and each of these may be complete or incomplete. Now let's turn to overjet. This is a normal overjet. This obviously is an increased, more increased overjet. And then we may have reduced overjet, which would be an edge-to-edge type of situation, or we may have a reversed overjet, which is the way some people describe class 3 incisor relationship. Now, you've seen that I've moved these teeth around and produced virtually I could produce an infinite range of incisor-tooth relationships without changing the relationship of the skeletal bases. This is the upper jaw, lower jaw. I haven't moved any of these things. I've just moved the teeth. And what has made it possible for me to rearrange these magnetic teeth on fixed jaws and thereby illustrate the whole range of possibilities of incisor relationship is that I've been tilting teeth one way or another. In other words, the axial inclination of teeth as it changes will influence the overjet and also the overbite. By axial inclination, I mean the angle which the long axis of this tooth will make to any fixed horizontal sort of plane. I could use the plane between the anterior and posterior nasal spines. That would be the maxillary plane or the Frankfurt plane or some sort of cranial plane like the SM plane. So this would be a normal inclination of an upper incisor. This would be a proclined upper central incisor. In other words, it has an increased axial inclination. And this would be a retroclined incisor with the angle between the long axis of the tooth and the horizontal plane is reduced, and that's a retroclined incisor. And the same would apply to lower incisors. Here we refer the inclination to the mandibular plane. That's the plane going down there. That's a normally inclined tooth. That's a retroclined or tilted tooth in the lingual direction, and tilting teeth in the facial direction will give you an example of a proclined lower incisor. And the thing that changes each time we change axial inclination of teeth is the relationship between the incisors and also this angle which is formed between the long axis of this one and the long axis of that one. In other words, the interincisal angle, the angle between the long axes of these two teeth. Okay, now I think that we all know what we're talking about, and it's really time to go and have a look at some of these things on a real life patient. Okay, well now this is Patrick, who is 10 years old, and we're going to try and go through some of the things I've just been talking about in the examination of a patient, illustrating it on Patrick. Now, first of all, we don't start a dental examination by saying to Patrick, open wide. We're going to have a look at the outside of his face first. So in other words, the extraoral examination is where we start. What I'm first looking at is the facial profile, and just looking at him, I can see that he has a skeletal 2 type of profile. The facial profile is class 2, indicative of a skeletal 2 dental relationship of the jaws. Looking at his vertical relationships, he seems to have a slightly longer than average lower face height, although the total face seems to be well within the normal range. I'm going to now just check on the Frankfurt mandibular plane angle. Right together for me on your back teeth, Patrick. That's great. Frankfurt plane, mandibular plane, and I think you could see that the lower mirror handle, if it was extended, would make an angle joining the upper one about there. In other words, nearer to the back of the ear than the back of the head. I think that he has a slightly above average Frankfurt mandibular plane angle, which goes with a slightly higher low facial height. Now, what about the functional aspects of the soft tissues? Let's have a look at his lips. Now, when he's relaxed, just let it go. Just relax completely. That's it. The lips are apart. In other words, he has lip incompetence. He has evidence of circumoral contraction when he brings his lips together. Just bring them together now. You just have a look at there, and you can see the activity of the musculature which is necessary to bring these upper and lower lips together. So he's lip incompetent. Morphologically, I would say, just relax again for me, Patrick. That's good. He seems to have a fairly shortish upper lip. Even now, you can see some evidence of circumoral contraction, even though the lips still haven't come into contact yet. Now, the mandibular musculature, as I said, morphology is impossible to assess, but we can see one or two things about how these muscles work. I've had a look at him before, and I know that he has got a normal freeway space. The way I looked before was just to part his lips, just relax as much as you can. You often have to take your time about this, just to get the patient well relaxed. And I'm now looking at the gap between the upper and lower teeth in the bicuspid area, and that's about 3 to 4 millimeters. Now back together for me, Patrick. Can you bring your teeth together? That's it. He has an upward and forward path of closure from rest into occlusion. Now, the other thing we want to see is how does he swallow? What happens to his lips when he swallows? And this is sometimes also difficult, particularly when the patient has nothing to swallow. So I'm going to ask you, Patrick, now to lick your lips for me and swallow. And you can just see the tip of the tongue retreating from between the teeth. In other words, he swallowed with his teeth apart. The tip of the tongue came into contact with the retracting lower lip, so he has a tongue to lower lip anterior seal in swallowing. Let me just see if I can do it again. I'll give you a bit of a rest now. When I say lick your lips, then do it, and I'm going to do the same as I've just done before. Now lick your lips for me. Now swallow. I think you can just make out the tip of the tongue, which is still there, and now going down. You can let it relax now. That's fine. So he has that type of swallow. Okay, now we've had a look at his facial form in a static way. We've tried to have a look at the dynamics, the movement patterns of the lips, something about the mandibular musculature and the tongue. How does this fit in with the sort of tooth relationship he has? Well, first of all, we'll have a look at his his arch relationships in terms of molars. We'll put the retractor in here. Just open wide for me. That's it. Close together, bite on your back teeth in the middle. That's good. Now if we turn his head a bit to the side, can you turn your head right round that way? I think it may be possible for you to see that he has got a class 2 molar relationship on the right side. Certainly you could see without too much difficulty that he has got, keep biting on your back teeth, an increased overjet. I'll show you all this on the models because I think it's so much easier to see. This is the class 2 molar relationship on the right. On the left side we have class 2, even more class 2 relationship of the molars. The overjet is increased. The overbite is not increased, and it's incomplete. If we look inside the models, we can see that there is no contact between the incisal edges of the lower teeth and anything in the upper jaw. No dental contact, no soft tissue contact. And this is not surprising because with a tooth apart swallow, with a tongue coming over the lower incisor teeth, you do frequently have this type of an incomplete overbite. Okay, well now, this is a cursory examination. It's by no means as complete as we would do in clinical practice, but I just wanted to try and put together facial form, static, dynamic behavior morphology, and the sort of tooth relationships which you might find with this combination of features.
You've now seen quite a lot about facial form analysis. I think it would be fair for you to be asking to yourself at this point, well, really, what's all this business good for anyway? What you've just been through is a key diagnostic procedure in evaluating children. It's important really for three purposes. First of all, you're going to be using facial form analysis as a step in screening out patients to select some for treatment yourself and to select others for referral for treatment by a specialist orthodontist. Secondly, facial form analysis is an important tool in deciding where you stand in physiologic timing. Some of the things that we talked about in the earlier module on establishing developmental age can be picked up in facial form analysis, and so your timing of treatment is going to relate to decisions you make at this stage. And thirdly, facial form analysis provides information that's very useful in establishing the prognosis of treatment, which is information that you need to share with the parents as early as possible. Clearly, the more severe the problems, especially the more severe the skeletal disproportions, then the poorer the prognosis for treatment is going to be, the more difficult and prolonged it's going to be, and the more the parents need to know about that early on. Peter, would you like to sum up some of the points you made in this extended analysis?
Yes, I think it should be becoming quite obvious to you now that if there were no muscles at all, the teeth, as they develop and erupt into the jaws, would reflect totally the relationship of the jaws themselves. Now, unfortunately, life isn't quite so simple, and muscles do exist, and therefore, I think for a full assessment of the patient, we have to look at structure as well as function. I think this is one of the fundamental points which should be emerging as being an important aspect of the examination. The analysis of facial proportions, which is a static way of looking at things, does give you a very good indication of the relationship of jaws to each other in all three dimensions in space. You're now also beginning to look at lips, not just as passive drapes around the teeth, but also more detailed way in looking at the form of the lips and also the function. In other words, morphology and function are now becoming part of your integral assessment. Now, once you start looking at bones, teeth, and muscles together, you are beginning to make sense of the interaction of these etiological features. I call them etiological because it is the interaction of these three things together with environmental factors, which we'll discuss another time, which give rise to variations in dental relationship, which give rise to both occlusion and malocclusion in all its guises, and which are also very important for an assessment of what time will do without help from us and what we can do in spite of the effects of further growth.
At this point, you've seen how to do an intraoral and an extraoral examination to relate the teeth to the soft tissues and to put together the information on how the jaws are related to each other and to fit that into the general pattern of development. You should at this point be able to fit facial form analysis into an overall concept of how the dental occlusion develops and how that relates to the growth of the jaws and the face in general. You ought to have some feel also for what equilibrium theory, muscles and tooth position means and how you can pick up some of that information which is important as far as the etiology of problems is concerned from your clinical examination. And you should be aware that you'll be using this information clinically to decide which patients to treat, which patients to refer, when to treat patients, in short, what to do and when to do it, which is critically important diagnostic information.